This is an introduction to person-centered care and person-centered recovery planning. This course was created for the Community Technical Assistance Center of New York at NYU McSilver Institute. My name is Anna Jackson, and I will present the 3 parts of this course. This is part 1. In this section, we will go over the basics of the course and introduce person-centered recovery planning through the lens of a framework called the 4 Ps. We will then introduce 2 of the Ps in more depth: philosophy and product. This course will provide learners with a foundational understanding of person-centered recovery planning, often referred to as PCRP, in mental health services. Through video lectures, interview clips, and practical exercises, learners will explore the 4 Ps of PCRP: philosophy, purpose, process, and plan. This course will emphasize the importance of a holistic approach that considers the whole person, their strengths, community connections, and right to self-determination. We have 4 learning objectives for this course. Upon completion, you will be able to list the 4 Ps of person-centered recovery planning, name one intended outcome or product of PCRP, list 2 important aspects of the PCRP process, describe what overarching qualities the written plan should have in order to uphold person-centered care principles. Here's what we plan to cover. We're currently going over the basic information about this course. After that, we will dive right into the 4 Ps. You'll see that the 4 Ps are spread across the 3 parts of the course. Part 1 includes philosophy and product. Part 2 is focused entirely on the process, and Part 3 covers the plan. We have a few brief closing notes at the end. There are exercises and resources presented in this course. Resources are indicated by the pushpin icon and can be downloaded on the CTAC website. Exercises are indicated by the pencil icon and can also be downloaded from the CTAC website. This course was created for the Community Technical Assistance Center of New York at NYU McSilver Institute and developed by Sidecar Consulting. A full reference list appears at the end of the course. Interview clips featured in the course highlight the experiences of people who have direct experience with person-centered care and recovery planning. They are mental health professionals, advocates, and people with lived experience. Their names and roles are displayed in the interview clips in which they appear. 2 resources are referenced throughout this course multiple times. The book Partnering for Recovery in Mental Health was written by Dr. Janice Tondora and colleagues with the Yale Program for Recovery and Community Health. It is a wealth of information, with exercises, knowledge checks, and stories that bring person-centered planning to life. The other resource, which is downloadable on the CTAC website, was developed by the National Center on Advancing Person-Centered Practices and Systems, NCAPS, and presents 5 major domains of competency for person-centered planning. This resource is referenced most often in the process section of this course and is a highly valuable resource for staff facilitating planning, supervisors, and administrators. It is also a useful resource for people receiving services and their loved ones, as it outlines what can be expected of professional supporters doing PCRP. You will see that the 5 domains are strengths-based, culturally informed, and whole person focused. Cultivating connections inside the system and out. Rights, choice, and control. Partnership, teamwork, communication, and facilitation. Documentation, implementation, and quality monitoring. While these topics are laid out somewhat differently in this course, they are all covered. This is a preview of the 4 Ps, which will be the focus of subsequent sections. What is person-centered recovery planning? Ultimately, this course is designed to answer this question. NCAPS, the center that created those 5 competency domains we just referenced, describes person-centered planning as a way to learn about the choices and interests that make up a person's idea of a good life, and to identify the supports, both paid and unpaid, needed to achieve that life. Let's dig in a little more. There are 4 P's of PCRP. Philosophy. The philosophy of person centered recovery planning is based on recovery oriented, person centered care principles. Product. PCRP is product oriented, it has intended outcomes. As you heard in that INCAPS definition, this is about a person's idea of a good life. A PCRP process is focused on the person, their strengths, and their vision of the future. Finally, the written PCRP plan reflects the philosophy, intended outcomes, and process that were used to create it. To become a little more familiar with how PCRP encompasses all the 4 Ps, not just a written plan, we invite you to listen to Ebony Flint, a person with lived experience, peer specialist, family advocate, and educator, tell a story about a young woman she supported and how. As you listen to the story, consider philosophy. What are some values that you hear reflected in the approach that Ebony took with this person? Product. What were the outcomes that this person really wanted? Process. What did Ebony specifically do to support the young woman in the story? And finally, the plan. What do you imagine might be included in her written plan?
A young adult who was identified as having both developmental disabilities and mental health issues or severely mentally ill. Her parents wanted to support her in going out and doing what she wanted to do in the world, but was very scared, of course. And she was very good at advocating for that, and I was her peer specialist. And so she wanted to get on the bus and go to work and be able to navigate on her own. And so I supported her to do that. Her parents were very scared and would want to talk to me about it all the time. And I'd say, ask her, et cetera, et cetera. And she would share, this is what I want to do. I don't want you all taking me everywhere. I'm scared to drive, and I'd drive to get her and we would catch the bus to Walmart and back. And so letting her be in the driver's seat, amplifying her on the side instead of saying all the things that she couldn't do, supporting her in what she could do. And when she was scared and not making that seem as a failure, or like, well, this is why you shouldn't do it, right? Um, Things like that.
What did you hear about the 4 Ps in the story that Ebony told? Here are some things that we hear in the story. Philosophy, a recovery orientation, which we'll talk more about in just a moment. It maintains high expectations. It's hopeful and affirming. The product, this is about outcomes. We heard that this young woman wanted greater independence, and Ebony helped her use her self advocacy skills. That's a shorter term outcome. Eventually, she did learn how to ride that bus, which improved her quality of life. Process. There is a lot in this story about the process Ebony used when supporting this person, but we'll highlight her amplification of strengths, encouragement of self advocacy. Remember when she said, ask her? Following her lead, and the involvement of natural supporters. Last, what might be in this young woman's plan? We don't see it, but we can imagine that would be organized around her desire to learn to ride that bus, her want of greater independence, highlight her strengths, and it would address some of the most immediate barriers that were getting in her way. In that example, you can really hear what a powerhouse PCRP is. It's not just about a written plan, but embodies a philosophy, an approach to working together, and is particularly outcome oriented. We will also talk about PCRP as a powerful catalyst for change at many scales. Let's talk about philosophy, the first of the 4 Ps of PCRP that we will cover in this course. The underpinning philosophy of PCRP is recovery oriented and person centered. So, what does that really mean? And does it really matter? It can sound pretty abstract. Janice Tondora, who has been at the center of efforts to implement PCRP in mental health care, emphasizes that culture and beliefs are critical to successful implementation of the practice. She says, person centered care planning cannot be fully implemented in the absence of a recovery oriented culture. It must be embedded in a system that is committed to changing not only what people do, but also how people think and believe about recovery and their obligation to partner with people to achieve it. There are many definitions of recovery published out there. Today, we'll use the SAMHSA definition as a starting point. It is recovery is a process of change through which people improve their health and wellness, live self-directed lives, and strive to reach their full potential. This definition has 3 major parts. The first is about health and wellness. The second is a self-directed life. And 3 is about pursuing potential. Importantly, this definition relates to a whole person, their desires, and their pursuit of the life that they want. But let's back up for a moment. Where does this idea of recovery come from? The answer is critical for understanding the recovery movement in mental health care. People with lived experience of recovery from mental health challenges, advocates speaking up and sharing from their own experiences. The voices of people with lived experience have really shaped and led recent shifts in mental health care. This quote by Mary Ellen Copeland, the creator of the evidence-based practice Wellness Recovery Action Plan, captures the importance and essence of this influence on care. We think it's important to share a bit of the history about this movement. The idea of recovery from and with mental health challenges has been around for a long time. There were glimpses of the idea as early as the 17th century. In more recent years, really for most of the 20th century, the prevailing paradigm was that people could not recover and mental health was increasingly treated with a chronic disease paradigm. In the mid-century, a lot of emphasis was put on medication and institutions. In the 1960s, deinstitutionalization was a big shift in policy. I think many of us are pretty familiar with that. But importantly, around this time and into the 1970s, when there was a lot of social activism and action in the United States, a grassroots movement started to emerge, with personal narratives of ex-patient survivors emerging and the alternatives to the mental health system being explored. For example, more and more peer support groups. With this leadership and these voices, it started to become a more popular idea that recovery is possible. Longitudinal studies were funded and showed that people, more often than not, went on to live full, meaningful lives. As we moved into the 21st century, peer workforces promoting recovery and wellness grew. Person-centered and self-directed care became increasingly popular. Since then, we have seen a much broader and more general appreciation of mental health, the need for trauma responsiveness, and serious focus on addressing health disparities and social determinants of health. Across all of this, the idea that people with mental health challenges can and have the right to pursue a meaningful life and recover is shaped by the voices and leadership of people with lived experience. And as Mary Ellen Copeland has put it, the shifts of the mental health system toward a recovery orientation have been and must continue to be led by people with that experience of recovery in mental health. She says, Only those who have experienced the depth of despair and the heights of recovery know what truly it takes to build a system that works. We must trust and support the leadership of those in recovery to transform the future of mental health care. In a moment, we will show a video with Amanda Bowman, a licensed clinical social worker and person with lived experience, reflecting on the influence of the recovery movement in her work.
For me, it's very grounding as a professional to understand that this is what people who have navigated the mental health system and navigated mental health challenges, what they are demanding and what they are saying they need. Because we talk a lot about evidence-based approaches. And what greater evidence is there than the people who have been experiencing and living with this, and to see them become organized in a way, whether it's by working alongside the professional peer specialist, community, or hearing people's stories of recovery, or advocates demanding for change. I think understanding the origins and how far we've come as a system can provide a lot of hope, and again, a lot of just grounding for what this is and why we're doing it.
Let's go back to this idea of recovery, which we assume is somewhat familiar to you. What are people really recovering from? As we just discussed with respect to the recovery movement in mental health, what we know about the experience of recovery comes from people who have been there and who are willing to share their experiences. So, what do people say about recovery? What have we learned? It is very common at first to primarily think about the subduing or managing of the symptoms of a mental health condition. And while that is relevant, when we really listen to the people in recovery, we hear that it's really just a small part of the big picture. It's estimated that more than 90% of people who receive mental health services in the public health system have experienced significant trauma, so that's a big piece. People are recovering from many of the social and personal impacts of having received an often highly stigmatized diagnosis and quite negative experiences, sometimes also traumatic, navigating the mental health system and its care. With significant interruptions to work and school, people often experience serious economic impacts and long periods of economic stability that also carries its own stigma. These experiences of discrimination, often even within families and with friends, along with the general discrimination, has a major impact on people's lives. In the midst of all these, people often lose hope about their future, their sense of power and self-efficacy, and real control over their lives. The impacts are multidimensional, individualized, and complex. In a moment, we will share a video of Amy Pierce, peer specialist, educator, and advocate, talking about some of her earliest experiences dealing not only with a mental health challenge, but the stigma associated with it and the impacts of that.
For me, it really started when I think about it. It started when I was around fifth or sixth grade was the first time my family really identified that something was going on, that something wasn't quite right. Like who they knew to be their Amy wasn't who was in front of them. And I lived in East Texas, and at that point in time in the early 80s, like you didn't talk about this. And so I remember going to the psychologist or a psychiatrist, and he talked to my family, he talked to my parents, and he gave me a medication at that time. And what he said to our family and to myself as well is that I needed to take this medication, but it was going to help me feel normal. What that did was it sent this message in my head that just really defined who I already thought myself to be, was that there was something wrong. And, that kind of was like one of those moments that sticks with me. And it sticks with me because it's that place where I see myself really slipping into um, some of the really deeper, darker challenges that I had in my life. My first hospitalization happened when I was in high school. It was a point in time where um, it was the first time my family found out that I actually didn't want to be here on this earth and had tried to leave this earth. And it was a unique experience for me because I didn't really understand like the heaviness of a diagnosis of a mental health condition or being put into the hospital until I started hearing from my family, like, don't tell anybody where you're at, right? Because of the stigma, because of the belief about someone who might be in a mental health hospital um, back in this time.
Given all this complexity, what really supports recovery? As we noted, yes, learning to manage and navigate one's own health and well being, symptoms, and experiences is part of the picture. And receiving truly individualized support, which is a big aspect of person centered, recovery oriented care, it matters. Having affirming messages like I believe in you from supporters of all types has some of the most data to support it from narratives of people with lived experience. As we consider that recovery from trauma, we can appreciate the importance of a sense of safety, power, and control over one's life. Along with that, when someone is ready, getting support to pursue their dreams, to pursue the life they want, and recover or develop meaningful social roles that draw on their strengths and support their learning. Being a sister, a member of a church choir, working at the library, these are the things that really matter. So, what supports recovery? In the next video, Ebony shares about really listening to what people tell us.
Pat Deegan has a quote: help is not help if it's not helpful. And so you may think you're helping me, but if I say that's not helping me, it's not helpful. Sorry, you know? And so keep that in mind when we take, our own bias out the way, or even experience sometimes, it's our own. Listen to the person, to the things that they share is helpful to them and support them with that, amplify that, you know. That doesn't mean lie to people or say what you think they want to hear. It doesn't mean treating folks as fragile, but it does mean listening, you know. And if I say this help just because your statistics say that it doesn't mean that that's not true. Doesn't mean that what I'm saying to you is not true.
The specific impact of recovery on mental health services is outlined in this chart, which helps us see that services that drive toward a person living a meaningful life are quite different from the stabilization and maintenance goals of our traditional mental health system. PCRP reflects the difference in emphases too, which you'll continue to see. On the left-hand side, we have the recovery and person-centered system that we're moving toward. You'll see that the meaningful life of a person is the desired result. On the right-hand side, you can see that our traditional system really was aiming to provide stabilization and maintenance. These are pretty different outcomes. On the left-hand side, what we're moving toward emphasizes hope for the future, choice, meaningful partnership, a focus on strengths, high expectations, the active participation of people in care, and the meaningful support of risk. In the traditional system, you can really see how this emphasis on stability, it made sense that in some ways, we were really thinking about compliance, not just with medication, but really related to um, anything that the service system deemed to be more appropriate for a person, which of course was controlling. And there was more of a focus on deficits and trying to solve problems than a focus on strengths or an amplification of strengths. Over time and with low expectations, people learn deficits by receiving services in the system. Instead of supporting meaningful risk, we were really trying to protect people from failure. So, in part, we show this so that we can fully appreciate the long way that we have come in the mental health system, but also the legacy that we still encounter often in our systems of care. Recovery-oriented care is what practitioners offer in support of a person's own long-term recovery efforts. A recovery-oriented system of care identifies and builds on each person's strengths, assets, areas of health, and competence to support the person while regaining his or her life and a meaningful, constructive sense of membership in the community. This way of approaching care is much, much broader than addressing symptoms. Obviously, it's really human, and it's about the person and their life, their community, and their strengths. One dimension of recovery-oriented care is that it's defined that it is person-centered. And by that, we specifically mean that it is collaborative and inclusive, that planning is strengths-based and empowering, relationships are central, and care is community-focused. We will unpack these dimensions more fully across this course and specifically within the process P of the 4 Ps. Moving on from the philosophical underpinnings of PCRP, let's talk about the product or outcomes that we're after. We can also think of this as the purpose of PCRP, why we do it. In this section, we'll talk about the intended outcomes, impact, and purposes of the approach of PCRP. Let's get started with the obvious, impacts at the individual level. PCRP is intended to support people in their pursuit of a higher quality of life, the meaningful social roles they want to fulfill, being part of the communities that they want to be part of, and really living the life that you really want. These outcomes are highly individualized, and the person's sense of these is what drive the specific dimensions of their plan, which we will look at later. But a person's pursuit of their desired future and moving toward that future, that is a core intended outcome of PCRP. Let's look at what the research says about the individual impacts of PCRP. The data says people experience improved mental health outcomes, specifically reduced symptoms of depression and anxiety, and enhanced social functioning and overall well-being. People report that they have a greater sense of control and recovery, an enhanced quality of life, especially personal autonomy, social connections, and community participation. This will make a lot of sense as we start to get into the specific elements within person-centered care. Increased adherence and self-management. Personal goal setting and active participation in care decisions improves self-management of symptoms and fosters sustained engagement in care. That feels really logical if you have a sense of your own care and the own services that you've participated in. The more that you are actively participating, the more that you have ownership. A higher satisfaction with services. People feel respected and heard, and it strengthens the therapeutic alliance. In this story, Amy Pierce talks about the specific impact on one person going through a PCRP process.
There was this one individual who had had just challenges for a number of years in her life, had been in and out of hospitalizations, had been houseless for a number of different times. And she was in our transitional living program, and she came in, and this was a new process for her. So it took a little bit of time in our kind of like initial exploring thing to kind of support her and kind of having that understanding of what we were going to do at the meeting. And I remember going into the meeting, and she had asked me to be a part of the meeting, just kind of that support. Um, and we had talked about different things. And so I had asked her permissions at different points to share things if she wanted me to, right? Only sharing from what she specifically stated to me. And we got in there, and she was quiet a little bit at first, and kind of kept looking at me at first. And they asked a few questions, and she was quiet, and I just kind of let her stay there, and we stayed there. She's like, I want to clean rooms at the hotel up the street. She loved to clean, like absolutely loved to clean. But one of the things that got in the way of her working in those circumstances is that she would have some intense experiences and lose her job. And so like I want to go back working at, like, there was a hotel, like this little hotel place. I forget what the name was. And then I want my own place. I want an apartment, right? She wanted an apartment, a 1-bedroom apartment, right? And we had talked about some of these things. And so she's creating this, the staff they're doing some brainstorming, like some different, like looking at some of the goals, right? And I watched her in that meeting go from kind of her head down, really quiet, because she was ready for them to tell her all the reasons why she couldn't because of what she's done before, right? And her head just kind of slowly was coming up. And then her smile was getting bigger, and like then like she was so bright. And we had this list of things, and then she had these things she wanted to work towards. And then, they created the plan. They came back. She looked at the plan of what was created. She agreed to some things. I know they changed like a couple things on that plan. And with that plan, like, she was surrounded by these different supports, from employment specialists to housing specialists to, she also had peer support. And then she had her other um, providers, and just kept working. And within 3 months, she had her job at that hotel, the exact one that she wanted to work at, right? She had her job. And then within, it was like 5 months, she had her apartment because she saved up her money from that job. And that meant that she still had that job, right? And I'll tell you that I actually ended up leaving Bluebonnet not long after that. And every time I'll see someone who works there, who works from there, which is, I probably shouldn't say this, but I am, they just said she's still doing it. Like, and I know exactly who they're talking about, and that, like, she's still doing it. And so she literally is still working, has her apartment, and is still out living life. And that's, to me, is what this process can do.
The product of a person-centered approach, though, isn't just at the individual level. To fully appreciate what results from PCRP, it can help to view change through different levels or scales within the system and community and society. The one we focus most on in this course is individuals and their families, but the changes that take root within service organizations like clinics, programs, and provider, staff, practitioners, they can be profound. In the philosophy section, we talked about how we appreciate how shifts at a larger scale have driven many of these changes. and even more broadly, shifts at a social scale with attitudes and paradigms about mental health continue to evolve too. We noted earlier that it isn't really possible to fully implement PCRP without a recovery oriented culture. Well, implementing PCRP turns out to help make that more of a reality. We hear from people in organizations implementing person centered planning and person centered care that the culture becomes more hopeful and recovery oriented. There's a sharper focus on outcomes. And staff begin to experience more meaning, and they feel an immediate benefit of doing work in a way that often aligns more closely with their principles and beliefs. At the service level, there's also some pretty interesting evidence that PCRP improves outcomes. The cost effectiveness of PCRP relates most directly to the decreased use of emergency and inpatient services. Staff often report feeling more fulfilled when they see clients progress based on their personalized goals that really matter to them. Being part of a more recovery oriented process seems to improve motivation and certainly morale, so people's job satisfaction increases. We noted this earlier, but this idea that there is a stronger therapeutic alliance when you involve people receiving services is something that shows up across different studies. Clinicians build deeper trust and rapport with people, which contributes to better adherence to the treatment plans, which makes a lot of sense. We often hear practitioners talking about that greater sense of alignment with their values when using PCRP. Staff often believe deeply in people and experience a high degree of meaning and satisfaction when they have tools and practices that enable them to work in a way that fully demonstrates this. To more fully appreciate how PCRP can influence the culture of an organization and how a stronger recovery culture creates the conditions for PCRP to be more fully implemented, Amanda, clinical social worker, administrator, person with lived experience, shares how she and her colleagues started to make some changes when they began to implement PCRP.
One of the changes that we decided to make that I still am really excited about today, that I recommend to other organizations to think about, was we asked staff to stop referencing the people in recovery as patient or client in the record and to begin to use their name. And I thought that that was a brilliant idea. I can't claim that it was my idea at the time, but it was so straightforward of an ask. It was very direct, but I felt like the impact that it had on all the staff was much, much deeper because we had been conditioned for years to speak about what we were doing in the third person. And so speaking about people in the first person and by name really did change the culture and change kind of the philosophy of how I was thinking and how people were articulating their work when they would sit down and do documentation, which is the time that you would often forget about the relational side of the work. And so that was one of the earliest changes that we made. And it seemed like initially a lot of people didn't want to do it and complained about it. But I feel like once people adopted that new way of speaking in their documentation, everybody really agreed that it had a great impact on the culture.
Let's take a moment to consider what all those outcomes we've been talking about look like if they're widespread, if they're at scale, without overstating and understanding that It can begin to feel very abstract when we move away from looking at the impacts at the individual and even at the clinic or at the staff level. Let's just take a moment to consider. If the individual outcomes that we understand are happening in a widespread way, people experiencing mental health challenges are living the lives that they want in the communities of their choosing. Our communities are being invited to be more inclusive places. The mental health workforce should be experiencing increased satisfaction, which should impact retention. Certainly, the effectiveness of care should go up. The recovery, peer support, and broader disability rights movements should continue to influence and shape culture, not just care, and impact shifts in attitudes and beliefs. And with that, we are concluding the product section of the 4 Ps. And you've made it through part 1 of an introduction to person-centered care and person-centered recovery planning. You've also completed 2 of the 4 Ps, philosophy and product. In part 2, we will focus on process and the person-centered principles of recovery-oriented care, which are: planning is strengths-based and empowering, relationships are central, care is community-focused, and care is collaborative and inclusive. We'll see you there.